everyone, welcome to The Breakdown. I'm your host, Brandi Christiansen, and we're going to be breaking down some stigma to mental health and addiction today. So without further ado, let's get started. Welcome to the first episode of The Breakdown. I'm Brandi Christiansen, President and CEO of Mental Health America, and I am your host. And I'm so excited that our first guest is who our first guest is, because she is a phenomenal human being. She has been with me from the very start of my career here in Tippecanoe County, and she does so many great things for mental health and addictions in the state of Indiana. Her name is Zoe Frantz. When I first got to know her, she was an advocacy chair and a board member on the board of trustees for Mental Health America Wabash Valley region, and the chief strategy officer, I believe, from our community mental health center here in Tippecanoe County, which is Valley Oaks Health. She has since moved on to be the CEO of the community mental health centers for the state of Indiana, and is really, really busy introducing and upholding and testifying for legislation that will drastically improve mental health care in the state of Indiana. So it's my pleasure to introduce Zoe Frantz.
Thanks, Brandi. Thanks so much for having me. So one of the things that I wanted to share, in addition to my role at the Indiana Council, when you and I kind of started our journey together, it really was also the time that I started my journey with the Indiana Behavioral Health Commission. That was a policy that was done a couple of years ago under Senator Crider's leadership. And so a lot of the things we're going to talk about today align not only with Mental Health America of Wabash Valley region, the community mental health centers in our state, but it is also the Indiana Behavioral Health Commission's great work and the phenomenal people that were on that commission.
Yeah, and that's exactly how we're going to start off today, because I know that just prior to COVID, the governor appointed that commission. So tell us about, well, first of all, about how your roles with the Behavioral Health Commission have kind of integrated into what you're doing now. And tell us, we'll lead about, if you can share actually about the Behavioral Health Commission itself.
Yeah, absolutely. So when we started the Behavioral Health Commission, it was really, I think, a few weeks before COVID. And so we wanted to make sure our recommendations were actionable, concrete, and specific. And we wanted to be laser focused on Indiana and what we could do as a state. And so where we started is the commission actually did a study, a wonderful study through IU. And what they found was the cost of untreated mental health illness in Indiana is a staggering $4.2 billion annually. And so thinking about that cost and how we can address such a great need, we needed to start with building a sustainable infrastructure. And so that's with using 988 as a crisis response, and then CCBHC, which stands for the Certified Community Behavioral Health Clinics. And then also along with this, needing to do the sequential intercept model for our criminal justice folks. And so we, started building that. And then the other two that, of course, kind of come alongside that is the overall Hoosier mental well-being. So like mental health literacy and what that means. And then also, of course, workforce. And so we really had quite a few things, but we realized then that if we didn't have the foundation, right, I really equate it to building a house. If we don't have that strong foundation, then everything else we put on from a policy standpoint, or really even administrative standpoint, is just going to be a fancy doorknob or a fancy window, and it will continue to crumble. And that's really where our infrastructure is at right now. It's bit, one of my members says, of a gaping hole, and we're trying to fill it with a plastic spoon. And these changes this session is really going to allow us to fill in that hole and really start building our system to what it needs to be.
And it really does feel different this year. I think I've been fairly attuned to the legislative process for the past couple of years, and it's exactly what you said. No matter what we threw at it, outcomes seem to be getting worse, and it's because that foundation really didn't exist. So for the lay people, when you talk about untreated mental health, what does that look like? Because you and I know what we're talking about, but how can we even measure that?
Yeah, so the report was measured, based off of, people who cannot work, people who cannot be able to, care for, others. And so they use those various metrics. And we have a one-page flyer from the great work that was done with the researchers that really breaks down why that 4.2 billion and how they got to it. And I'll make sure I did email that to you prior.
We're going to share, everything with them.
Definitely something that should be shared so that people can understand the cost adds up when people are not getting treatment, whether it be in our jails, whether it be in our hospitals, whether it be in our workforce. And so having that infrastructure in place is really going to help in addressing those needs.
Yeah, because we have to admit that the system is broken before we can fix it. Mm-hmm. And so up until this point, right, a lot of the choices that people are given as they're being addressed in a mental health crisis is, do you want to go to jail or do you want to go to the hospital? Mm-hmm. And I think we can all agree that neither of those places are a very good place to be when you're in the middle of a mental health crisis. So I just want to be able to quantify that for our listeners and maybe sort of explain when you're talking about the CCBHCs and the CMHCs, there's a lot of acronyms to describe. So the CMHC, which is the community mental health centers, those are the mental health centers. I mean, you're probably best able to describe them for our listeners, but also like how did the CCBHCs come to be, and what is their role going to look like as we move into this infrastructure that you're talking about?
Yeah, so the best way that I like to explain it is this picture behind me. So back in 1968, JFK signed the Community Mental Health Act into law on a federal basis. And that was really focused to get people out of state hospitals. That was the intent of that policy, which is a phenomenal intent. And Indiana really has done a pretty good job at getting people out of state hospitals with our 24 community mental health centers. What that policy didn't do until the recent past years of certified community behavioral health clinics is it didn't give a model for that community-based treatment. And so states had to really define it for what it is for them, and also put the structure, the reimbursement structure in place for what it is to them as well. And so out of that came, at the time it was more than 24, but the current 24 community mental health centers, and they provide the full continuum of services to all 92 counties, both behavioral health and substance use treatment services. And then if not, they do memos of understanding with, inpatient or, other services that they might need to be able to help those individuals. But it doesn't really give the structure and the reimbursement for care coordination, which care coordination is so key, whether it be working with a school, a jail, a physician, especially with those with mental illness and substance use. It also wasn't a system that really allowed for peers. And I know Mental Health America has done a lot of work with peers, as well as a lot of my members. And so for those of you who don't know, a peer is someone with lived experience. And so we have found through research that peers, whether it be in substance use or mental health, are really the ones that need to be able to connect with folks to get them into treatment. I really equate it to I'm a burn survivor. And if someone comes up to me and says, "Oh, I got burned by a curling iron," I would say, "Oh, I'm sorry." And so for me, having a lived experience to be able to educate and help other burn survivors, that's a connection, right? And it's very different, or it's very similar to substance use and mental health. So the peer part is really a focus of certified community behavioral health clinics, as well as mobile assessment and open access, getting people treated, the treatment first model. So it removes a lot of the administrative burden up front to be able to provide treatment, get people to where they need to be. And not all of them will be at the community mental health center or the certified community behavioral health clinic. It could be organizations like Mental Health America. It could be other, organizations, and that's through a designated care organization is how those are organized under the certified community behavioral health clinic. Does that explain the differences?
Yeah, I think it does. I think it gives people a good starting point to if they want to start looking things up. And it's also a good segue into why are we talking about peers so much? Why are they so important? And I always equate it to, I'm a veteran. I'm not a battle veteran. However, there is a complete cultural experience that each veteran goes through when they, take their oath and serve their country. And a veteran will have much better outcomes talking to another veteran. Absolutely. Generally speaking. It's the same thing with domestic violence survivors. People want to speak with someone who understands what it's like to have walked through that path and are an example of, a person being in recovery, someone that they can relate to. It shines a certain kind of light. So one of the things that Mental Health America Wabash Valley region has always said is we've called it lived expertise instead of lived experience. We know recovery is not a destination, it's a journey. And, we feel like if we know the path, we have a responsibility to light it for others. And that's, basically what we're saying. So we're tying our CMHCs, our community mental health centers, are tying the peers, the clinical experience, removing barriers to access. That's all the infrastructure that we're talking about. And, that's all going to coincide with this thing that we talk about all the time, which is 988, this crisis now model, this new response system that you're talking about, that we're actually a part of as well, because it's a person to call, someone to show up or to respond, which are your CC BHCs, right? Your peer.
Could be.
Mobile, it could be your mobile response teams, and it's a place to go. And that's basically the crux of the legislation that we're trying to get passed this session, along with funding mechanisms. So let's talk about 988 a little bit. Can you describe how you think that this in particular is going to be able to help out some of those rural health facilities that don't have access to the resource-rich communities like, say a Marion County or Hamilton County?
Yeah, absolutely. So, for so long, we've had 911. And that is, to respond to physical emergencies. And 988 was federal law, and it passed. And we rolled that number out July 1st. But the Behavioral Health Commission and a lot of key stakeholders, even beyond the Behavioral Health Commission, have a vision that it's more than just a call center, right? Your folks do great work. You have wonderful crisis. I mean, gosh, how long has the crisis line been done at Mental Health?
51 years.
Yes, I was going to say it's been quite some time. But what we've been missing is someone to respond and a place to go. And so through some of the pilot funding for the certified community behavioral health clinics and some other pilot funding that the Department of Mental Health and Addiction put out, we've been able to start doing some mobile assessments. And what we've seen with that is we've seen greater results of getting people connected to treatment and getting connected to services versus connected to an emergency room or a jail. And in one of my rural markets, my members, they collaborate very well with the police and they work with them in those responses. But they have seen a dramatic shift in those getting connected to treatment. And I think that's the important thing with this mobile assessment team is sometimes it's going out there and it might just be getting that connection right then and there to outpatient or who's your therapist? Who are you involved with? Let's make that connection. Let's get that service going for you again versus immediate, let's go to the emergency room or jail because of the situation, right? So the mobile assessment, and then let's say they do need to go somewhere, then crisis stabilization units. So these units are different than an emergency room. Some of them are set up like almost a living room where there's recliner chairs where people can go decompress, be able to see a psychiatrist, be able to see a therapist, maybe get their meds addressed, we're talking short term. And then if they need something longer or need to be connected to services, then they could either get connected to a longer inpatient or they could get connected to other outpatient services. And so it's really being intentional on a crisis response system, not a call center. In federal law, that is what the law reads, is it's 988, someone to call, a place to go, someone to respond, and a place to go. That is what their vision is. And Indiana was really ahead of this last legislative session because we actually built a policy that included 988 and certified community behavioral health clinics together because we realized that that's the infrastructure change that we need. If you just had 988, you wouldn't have a place that people could go and people to respond. If you just had certified community behavioral health clinics, you wouldn't have folks such as yourself being able to answer and triage. Not every call, as you know, is going to get to that certified community behavioral health clinic. Not every call is going to get a mobile assessment, right?
Ideally, no. We do a very great job. And when I say we, I'm not just talking about our call center. I'm talking about collectively as a state. I think 98.5% of our calls our callers are stabilized on the line.
On the line, yeah. And so, it's really in my mind, people talk about parity, and I kind of, when some, mention that, I kind of, say I'm kind of tired of talking about it, right? It's about time people
It's the same conversation.
It is, it's the same conversation. To me, 988 is the same as 911. And why for so long have we addressed our physical needs different than our mental health needs when really they end in the same result: untreated mental health.
Stigma, Zoe.
Yes,
Stigma.
Right.
And it plays out in legislation. It plays out in policy. It plays out in workflows. So that's what we're trying to change.
Yeah, that's what we're changing. So, so I couldn't be more thrilled to be working alongside Senator Crider. And Senator Crider has been really our mental health champion, our advocate, my hero. He has really taken mental health at the State House. And so for the first time, I think in Indiana legislative history, mental health got a bill number of 1. And for those of you that don't know the legislative process, the priorities of the bills are assigned by the number. So to hear that news several weeks ago, that we through Kreider's great work and so many people, like this has not been an individual effort on anyone's behalf. It's been work of, I can name, a few who have really been driving that, but Jay Chaudhry, the director of mental health and addiction, phenomenal leader and collaborator, led the Behavioral Health Commission and has been working to help in driving the state to this infrastructure. As well as all of the members on the Behavioral Health Commission. The governor's office, the lieutenant governor has been super supportive of these efforts. She came and testified for Senate Bill 1. We had everyone from the Teachers Association to the Indiana Chamber to the County Association come and testify in support of Senate Bill 1. So probably around 15 or so. Faith of in Indiana has been another advocacy group that's been very instrumental. So it takes all of us, right? And so
we got to give a little love to Ronnie.
Oh yeah, Ronnie, absolutely.
I mean,
yeah.
He's been pushing this. He made that introduction to us with Kreider right in the middle of COVID in July. Do you remember that?
Yeah.
So I got to give a little love.
Ronnie Alting definitely has been a mental health advocate, as well as several others. Ann Vermillion at the State House, Ed Charbonneau. Yeah, there's been quite a few, and
it's bipartisan.
Claire, yes, absolutely. So there's been quite Chris Campbell, Sheila Klinker, in our areas, a huge supporter. And we're even working now even with the new legislator, Spencer Deary, who just got elected in. So, but, as far as the champion and really who's led to be able to get Senate Bill 1, that is Senator Kreider. And so we started this journey together back when the Behavioral Health Commission came into place, and he has seen it through. And so yesterday it passed out of the Senate committee, so it will continue to move forward, which is very exciting. And then we're going to be working on the House side, and that's another representative who's been very helpful this session, Representative Nagel.
Yes, we have to give some love.
Yes, she has been very willing to be, helpful. So we have this alignment that I really have never seen before. And one of my lobbyists who I work with said, there's really not a time in history that this has ever happened, nor will it ever happen again. So we need to really ensure that we keep this aligned and we keep focused so that we can get 988, the appropriate funding, so your group can do the great work.
Let's talk about that. That'll be our next thing. How are we going to sustain this? I mean, because I mean, I had the honor and privilege of testifying for House Bill 1468, and it I think it was that 21.
Yeah, rough. Gosh, I don't know. I think
it was
so.
21.
It's such a blur. Yeah.
and it gave us a nice little bucket, but it didn't give us a funding mechanism. So what are we doing to sustain the system? You know the answer. I want to hear, and hopefully we're going to be able to push this video out so other people will hear it. Please tell me what I want to hear.
Yeah, so we are advocating for a surcharge. For a surcharge just like 911. That is how 911 is funded. So same parity, same thing. $1 surcharge that will be on everyone's cell phone bills through all of the telecom. And that will fund the system by $90 million annually. We are also advocating for the state is going to be submitting a waiver for mobile response, mobile assessment to CMS. We have seen on a federal level, a number of those have gotten approved. So we need that piece too, right? Mm-hmm. And then we are also advocating for bridge funding for the certified community behavioral health clinics. Because right now I have 19 pilots. Mm-hmm. So they're in certain areas in certain communities. So I can't even say 19 CMHCs. It's 19 pilots with the CMHCs doing those. And they have been able to service and open access to over 600,000 individuals since this funding rolled out. And without the sustainability of that model, those services and the work that all of those pilots have done will not be able to sustain until we get to the federal model in 2025/2027 through the state plan amendment process. So Department of Mental Health and Addiction, Ari Nassari's leadership, as well as many key stakeholders there and through the council and through my members, we submitted the application to be planning for the certified community behavioral health clinics on a federal level. Okay. We'll have a year for that. Then after that, we would get that approval to be able to then be a demonstration state. And we would have to demonstrate the success of that model. And then you submit the state plan. So that's one thing I like to really stress to people about 988 and CCBHC. We need to build not only the sustainability for the future, we need the upfront cost now, right, to be able to do it right. And then we need to have that vision long-term for that funding. So that's through the dollar surcharge. And then it's also through the bridge funding to get us to be able to get that federal demonstration through CMS.
Okay, that's what we're hoping for. We're going to give people the opportunity. We're going to post our toolkit here, talking points, a link to be able to be connected to the appropriate legislator for their region. And, that's how people can advocate. Are there any other ways that people can advocate for these changes?
Yeah. So, I really think the local voice is so powerful, right? And while I'm at the state level and, working on that macro, there is nothing like a local connection, being a local constituent and sharing your story, right? There's 1 in 4 of us that have been impacted with mental health, right? Whether it be ourselves or a family member. And so sharing that story and sharing how having a system like 988 and the certified community behavioral health clinics would have been helpful in that story at that time, and telling those stories, right? Because I can share numbers because that's what I get on that macro level, but it's really sharing those individual stories that really helps us to get people to make that human connection, because these are lives we're talking about. These are lives of loved ones. These are Hoosiers. And so we are in it for the well-being of all Hoosiers. And so I think just sharing that message and advocating for that on an individual local level is really where we're going to see this get to the finish line.
And I'm so glad you brought that up. We do have a local legislative forum that is open to anybody. It meets on I believe the first Monday, but we'll also put that out on the website so that people can access that. Dr. Monique Kulkarni is currently chairing that committee as I stepped down to be able to focus on really getting our 988 center up and running and getting our collaborations with the local CMHC. And I hate to throw acronyms because I know they can be completely disorientating if you're not in the business, but just wanted to thank you so much for taking some time out of your day. It's always so great to see you, and it's always a good conversation. Thank you for your efforts at the state. Thank you for bringing me to this great region and always keeping us informed.
Yeah. And Brandi, thank you. And please thank your staff and the wonderful crisis, service, that you guys provide. I think it's one of the best kept secrets. And so please thank them. And this infrastructure will help in addressing the workforce needs as well. I'm convinced that long term, we will be able to fill our workforce and we will be able to have better access as a result. So really looking forward to continuing this journey with you. Thank you for your leadership. And I hope that we can get this to the finish line. Just go out there and connect with your local legislators.
Yep, we're going to do it. I'm sure we'll have you on again, Zoe. Thank you so much.
Awesome.
Have a great day.
You too. Take care. Bye-bye.